In the exam, my students themselves will ask, when we start off the posting, madam, in exam squint will come. Now, if I say no, then you know what will happen. When I am seeing patient, they will be doing WhatsApp. So I have to say yes. Okay, but the truth is in exam you can get some palsies, third nerve, hopefully no fourth nerve, hopefully no pediatric. Okay, but in truth, in real life, most of our patients, squint patients, are pediatric patients. Okay, so this talk is going to be a mix of both. This is a video to show what a tough life it is. So now she started pushing me off. Ayyo, again. So I can now only about say, okay, maybe something is going on in the eyes. And this child doesn't like me. Just imagine we have to do surgery. Well, the point of this talk is it doesn't have to be this way, okay? This is just to show you how bad it could be, so let it not scare any of you. Okay, what are the goals of examining a squint patient? First, you want to establish a cause. Why did the squint happen? You want to assess the binocular sensory status, which means does this patient have any fusion, any binocularities, some stereopsis? You want to next measure the deviation, because like I tell my patients will always, parents will say, you can't do surgery because they think their darling child is so cooperative and sweet. I tell them this is not like tailoring. You can't look like this and do surgery. You have to measure, okay? And even if you measure, it will be a little bit either, udhar, as they say. Next, you have to diagnose amblyopia. You want to know whether this squint has resulted in loss of vision, because that has to be treated before you do anything to the squint itself. Okay, so those are the goals of any examination. So like history, like you have a history in ophthalmology, you ask some specific questions in a squint patient. Is the strabismus constant or intermittent? Is there any associated face turn or head tilt? Why do you want to ask this? Because it means there is some possibility of fusion, which is a good thing. Next, you want to know what was the onset of the strabismus. If the eyes were straight in the first few months of life, again, there is fusion potential. That means it's a good thing, okay? Because remember, correcting the squint goal is not just for the patient to look good and get married, which is how most of the patients come. They come, abhi shaadi hone wala hai, so, please can you kuch kariye? Nahin. The main reason is because we want to give the patient a chance at the 3D vision or binocular vision, okay? Is this squint acquired? Because it may be because of a neurological or systemic disease, because maybe some very bad tumor is presenting as a third nerve, okay? So you want to know whether this is an acquired strabismus. Also, if the patient has any diplopia, it means it is likely to have been likely to be an acquired strabismus. And then it's nice to somehow look at the old photographs and all that. If the patient can bring, some of them will take it off from the wall and all and bring you framed photos. It's nice, for example, if you look at this patient of mine, see, if you see on top, his eyes look fairly aligned. Okay, maybe a little hypotropia here. Well, again, a little bit hypotropia here. Looks well aligned. Aha! Now the eye went up. Okay? So now when we took the history, we found between this and this, he had some surgery. And then, but no records, only surgery, only saying I had surgery, nothing. Then when we went and looked at the eye and realized that this was going up because of inferior oblique overaction, we could suspect that maybe he had a Brown syndrome and they had knocked off the superior oblique. Okay? They had done a superior oblique tenotomy and then it resulted in an inferior oblique overaction. So photos are helpful. That is the bottom line. You also want to know what was the previous treatment history and compliance with history. Were glasses given? Were contact lenses given? Was there any patching, frosted glasses? Were prisms used? Orthoptic exercises were used, including anti-suppression exercises. So you want to see all the old records and get an idea of what all might have happened. You want to know about birth weight, complications of birth, because if in low birth weight, esotropia is common. Complications of birth like forceps and vacuum superior oblique palsy is common. You want to know what is the health of a child, because if child had a stormy perinatal history, child may have a cortical vision impairment in addition to your squint. You want to know how the developmental milestones are, because when the milestones are delayed, the outcomes of surgery is not very good, outcomes of squint surgery. You want to know if there's any family history of squint problem, then you want to intervene early. Okay, so now we're going to take a tour of my floor and my room, okay, and how we are going to go about my OPD. This is my room number, 522. I welcome all of you. First, ensure the patient is comfortable. Now, this is a little big boy, but he complied to my request and sat on his mother's lap. What do you need to examine squint? There, it looks like fun, right? It looks like a toy shop. Actually, it's quite a bit of fun. I should not have shown you that first video. Okay, you can see you need some toys. You need sticks with a lot of pictures, so that which are accommodative target. Things with details, that is the bottom line. You want to have an occluder and a set of loose prisms. Quite inexpensive to start a pediatric ophthalmic squint practice. That much I can assure you. Okay, occluders could be translucent occluder, can be a solid occluder, fancy occluders, no torchlight. Torchlight is only to get an idea with Hirschberg. You cannot use the target torchlight as a target because it is a fuzzy ball of light, a fuzzy light. So it does not give you details. So it is not an accommodative target. Okay, you need something with details. Aha, television. That is something with details. Okay, so you have if you can mount a television in your room. Of course, the parent is asking, "What TV देखता है? आप कुछ please आप बताइए." And then here you are putting on television for the child's examination. But it's okay. It really helps. It is in older children. You can also use targets, with Snellen or a layer symbols, and a good bag of toys, like I already told you. Okay, what are the steps of examination? As always in clinical medicine, observation. You want to inspect the eyes and if there is presence of any head posture. Evaluation of sensory status. Remember, in ophthalmology, we always start with vision, right? Is that what you've all been told? We start with vision. Whereas when you examine a patient of squint, you want to start with the sensory status, which means you want to know whether the patient has fusion, any binocularity, any stereopsis. Because remember, once you occlude the eye, you're breaking fusion, right? So even if the patient had kind of fusing, you would have broken the fusion, and then you will get a wrong information when you test the sensory status. So start with evaluation of sensory status, then only visual acuity estimation. And then you have to do the refraction, test the ocular alignment, anterior and posterior segment examination. So sometimes you will have to take a good look at the patient, not just the eyes. Can you see what's going on? What's going on? Yeah, chin up posture, but you see the webbed neck? Yeah, this is Wildewang syndrome with the Duane's retraction syndrome in the eyes. Okay? So let us move on to inspection. So we talked about inspection. You want to look at the lid and lid fissures, epicanthus, ptosis, fissure changes, any jaw winking. What is the position of the globe? Any retraction, ocular alignment, facial asymmetry, nystagmus, and pupils. Okay, I'm just going to show you the head posture, and you're going to shout out what the head posture is. Left head tilt. Come on, yeah. This is very simple. Chin down. Left face turn. Aha. You're all very good, man. Okay, sensory system examination. What are the goals of the sensory system examination? We want to establish again is if there is any diplopia, suppression, which means one eye is not being used under binocular condition. Any presence and degree of amblyopia, type of retinal correspondence, and stereopsis. And I promise you I won't go into detail into any of this. Okay, so basically we'll focus on fusion, retinal correspondence, and stereopsis. So tests for suppression are the Worth 4-dot tests. That's pretty easy, right? All you have to do is to slip on some red-green glasses and show the target on your, which is usually there on your Snellen, the 4 dots, and ask the patient. So this gives you some idea about whether there is suppression, whether there's fusion or diplopia. Okay, so that's the first level or the first degree of binocularity, and you can assess this with a simple test. Of course, if you have 4 prism base out test or Bagolini striated glasses, they give you a little bit more information as well. Tests for stereopsis. How many of you here are familiar with tests for stereopsis? The Titmus fly or the Randot, that's a good number. So again, you give a Polaroid glasses and ask the patient to pick the wings of the fly for gross stereopsis, and then as you go to the tougher and tougher parts, you get finer and finer grades of stereopsis. Okay? So if you think about it, the patient, the child also thinks that this is a game, right? First you're putting some goofy red-green glasses, then you're giving some cool-looking dark glasses. So the patient is now warming up to you. And meanwhile, you already have some information about whether the patient has some degree of fusion. So distant stereopsis, we're not going to dwell on it. So let's jump into the components of the motor examination. So you have tests for ocular motility and ocular alignment. So the ocular motility can be separated into ductions, versions, and vergence. So what are ductions? Very good, uniocular movements. What are versions? Conjugate, binocular, we like all these fancy terms, conjugate, binocular conjugate movements. What about vergence? Yes, binocular disconjugate movements. And then I always think, I have to show only one slide like this for people to run away from squint. If you thought this is sursum abduction, sursum adduction, if that you thought was bad, look at that. Okay, that's all you need for people to run away. Okay, don't worry about all this. You remember dextroversion, levoversion. Okay, and if you want to be simple, you just say elevation in adduction, elevation in abduction. Okay, don't get hung up on this fancy terminology and run away. So we're just going to just show you ocular motility examination. Remember, dextroversion, levoversion, always come back to the center. Dextro elevation, dextro depression, and then lift the eye, because you want to see if there is any lid retraction on down gaze. Levo elevation, levo depression, and then lift the eyelid. Okay? Up and down are not pure movements, but they give you some idea about head postures and lid lag, etc. Okay? Is that clear? So always come back to the center. People always ask, what is the ideal way to do ocular motility? That's all. That's as simple as it is. So let's move. Now ocular motility is over. Can you imagine how easy that is? Ocular motility over. Now we're going to go to ocular alignment. All right. So we have, which are what we call as the corneal light reflex test, and then we have the cover test. When do you do the corneal light reflex test? What is the indication? Why not do a cover test? Why do a light reflex test? Correct. This will only tell you tropia. There, not there. Squint there, squint not there. That's all it will tell you. Okay? It will also tell you how much squint is there, but it will not uncover the fovea. Very good. That's one good answer. Any other patient where you cannot use the cover test? Speak up, no, please. Eccentric fixation, poor vision in one eye, because when you cover one eye, this patient needs to see something with his eye. If the vision is too poor, imagine there is a corneal opacity in the right eye and there is a sensory squint. The eye has drifted out because of the central large opacity. Patient's vision is count fingers. Remember, patient needs to be seeing an accommodative target for you to do the cover test. Hence, in such a patient, you would use a corneal light reflex test. Okay? So the answer in the exam, when will you prefer to do a Hirschberg or a modified Krimsky test over a cover test, is when the patient has poor vision and cannot do a cover test. Okay? All right. So moving on. Modified Krimsky test is a little bit more quantitative. If you look at here, I will go back to Hirschberg. I forgot to talk a little bit more about Hirschberg. So as you know, you just shine the light and look at the amount of decentration of your light reflex. And 1 millimeter is equal to 7 degrees. So what is it if it's at the pupillary edge? 15. And then what is it if it's at the limbus? 45. Okay, and in the midpoint is 30. That's exactly right. So modified Krimsky test, you make it a little bit more quantitative. And what do you introduce here to make it quantitative? A prism. You use a prism. But remember, both these tests are for alignment at near. Okay? So you are measuring what the patient's alignment is at near distance. So in modified Krimsky, you place the prism in front of the fixating eye and you shine a light till the light is centered in both eyes equally. Okay? So that is as simple as it is. Cover test. So we're going to go over the cover test in very simple language. When do you do the cover test? It's done after the sensory examination. You cover with an occluder, or you can cover with the thumb and the palm. Do you remember in that video that the little girl kept pushing me off while I was trying to put my thumb and my palm and all that? But some kids will allow you to do that. They may be a little bit more intimidated by a solid occluder coming in front of their eyes. So the patient has to wear the best correction. Remember, you want this patient's accommodation controlled. You want the patient's acuity to be the best possible. So the patient needs to be seeing well. So the patient has to wear his or her glasses. So in fact, it's always my first check. So I'll call my PG and say, come do a cover test. And then patient will be a -5 myope. And I would have taken off the glasses. And I'll be waiting what they're doing. And immediately they will take an occluder and start doing ding, ding, like that. Ha, 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 show and some kuchis, so and stick and all that. Fail. Okay? First thing you need to know, what is the patient's vision? So the first question you ask in the exam, if you have to evaluate a squint patient, is, do you wear glasses? Put them on. Do you wear glasses with bifocals? Put them on. At near, you measure through the bifocals. Distance, you measure through the top part. You use an accommodative target, a near chart with details. For the near test, use a Snellen for the distance where the patient can see details. Okay? All right. So, as I told you already, not a torchlight. Do not hold up a torchlight and do a cover test. Fail. All right. So, what do? You cover one eye and watch the other eye. If there is a movement. If there is a movement, what do you call it? Tropia. Simple answer only. Nothing fancy. Tropia. So if you don't see any movement, what do? Remove the cover. And now what do you see? What do you look for? Yeah, you want to see if anything happened underneath the cover. The uncovered eye, the eye that you just took off the cover, had that eye gone up or down or, east or west or whatever. Okay? So, very good. So you cover one eye. If the eye moved, did the eye move in or out or up or down? If you're not sure, then do it again. Okay? Yes, it moved, it's a tropia. No? Are you sure? Cover again and watch. Still no? Then we move to the next step. So the other thing you do is watch the eye that moved. Does it hold fixation? And if so, for how long? Okay? So now we will go on to the next step. Remember, we covered first. Now we are going to uncover. Watch the uncovered eye. Any movement, then it's a phoria or a latent squint. So repeat the steps in the other eye. Repeat as many times as it takes to be sure. What do you do in alternate cover test? You alternately cover the eye. And that brings out the total deviation. Tropia plus phoria. All right? Now you want to know how much squint, right? So you have to introduce a prism. So you hold up a prism and then do the same thing. You do the alternate cover test with the prism, and then it is called the prism-based cover test. Okay? Or the alternate prism cover test. So the end point is no movement or reversal. We won't go into the special situations, but what I'm going to do is go on and show you one or two small clips so that you can participate and tell me what you see in these little videos. The limitations of a cover test are, of course, vision, as we talked about, and cooperation of the patient. Okay. What do you see in this child? Just first glance. Can you tell what's going on? Well, this is, again, just one more video to show what all the ways you can cover. Okay? So just watch how we do the ocular motility and cover test in a little baby, in a child, and the other two will be in older kids. So you can see me covering with the thumb. He's got a ptosis of the right eye. And I want to see if there's any. Yeah. This is the induced tropia test for vision in a preschooler. We're not going to talk about pre-verbal child. We're not going to talk about that today. Next time, I promise you, I'll bring a more cooperative patient. So, but you can actually do an alternate cover test. Look at that. He finally got used to it. Oh, now he's trying to fall off. Okay, so now we'll look at 2 more examples. Then I want you to look closely and tell me what you see in these patients, okay? Where's that arrow? There it is. Cover, uncover. Cover, uncover. Did you see anything? What was that? Cover, uncover. Aha. Exophoria, very good. Can you see that only the uncovered eye shows the movement? Yes, exophoria. Very good. And this is at near. I'm sorry if this sounds basic, because one of my PGs told me, please show cover test. There it is. What is this test called now? Alternate cover test. Now the patient is looking far away. What's happening? Yeah, left exotropia. Do you see that? Now it's right exotropia. Ah, went back to left. Do you see that? With single cover she broke and then she's there. The left eye is out there. Ah, went back again. What is this test called? Alternate prism cover test, or PBCT, prism-based cover test, or prism bar cover test, some people call it. That is the simultaneous prism cover test. And this shows you only the tropia. Okay, so if you want to conclude this child's diagnosis, okay, or if you want to conclude this child's ocular alignment findings, what would you call it? What is she for near? Yeah, a little bit more qualification. What phoria? Okay, near exophoria, and distance? Distance exotropia. And with preference for which eye? Right eye. Excellent. Fantastic. Now we'll go to the next one. Okay, watch again. Car, elephant, she's reading out. Anything going on? What is that test again? Alternate cover test. Nothing was happening. What did you see? Yeah, exophoria, maybe tropia. No, in between, kind of. That's right. What is this test called? No, we're doing cover, though modified. Cover test, alternate prism cover test. Okay? Watch, prolonged cover. What's happening? Exophoria, right? There. Not, okay, we're going to stop with that. So, very good. I think you're all fantastic. I think all of you should take up squint as a profession, passion, fashion, whatever. So, fantastic. Well done, audience, and thank you for your attention. And Santosh, thank you so much for this opportunity.